El Colegio Mexicano de Ortopedia, en su 75 aniversario, presenta su segundo Congreso Virtual 2021. El doctor Alan Barber es médico titulado en Baylor College of Medicine en Houston, Texas, especializado en ortopedia en Tripler Army Medical Center en Honolulu, Hawái. Fue jefe de cirugía ortopédica en hospitales militares tanto en Alemania como en Fort Knox, Kentucky. En el William Beaumont Army Medical Center. Fue jefe del servicio de cirugía de pie y profesor de tiempo completo del programa de residencia en cirugía ortopédica. Se especializó en cirugía artroscópica y reconstructiva en el Medical Arts Hospital en Dallas, Texas. Ha publicado numerosos artículos sobre lesiones de rodilla, hombro y medicina deportiva, y ha participado en la elaboración de diversos libros sobre temas de su especialidad. Además, es editor de la sección de hombros de la 4ª edición en Operative Artroscopy y editor del libro Surgical Techniques for the Shoulders and Elbow. Es miembro de las juntas asesoras editoriales de varias revistas profesionales. Actualmente es profesor clínico asistente de cirugía ortopédica en el Centro Médico Southwestern de la Universidad de Texas, Dallas, y es investigador y consultor para diferentes compañías. El Dr. Barber hablará sobre anclajes artroscópicos de Bankart, cuál, dónde y por qué.
I appreciate the opportunity to talk about Bankart repairs. Bankart repairs are anchor-based by and large. These are my disclosures. And for success with a Bankart repair, you need a careful examination under anesthesia to understand the principles of what's going on, clear visualization of the joint and the area you're going to operate. This requires a lateral decubitus position to really get to the anterior portion of the glenoid neck, hypotensive anesthesia with a systolic under 100 to avoid bleeding, a pump, which also helps flush the blood out and give you a clear visual field, and clear working cannulas. Patients under age 20 tend to do poorly. Patients with high activities with contact, engaging Hill-Sachs lesions, Hegel and reverse Hegel lesions are fraught with problems, and patients with significant glenoid bone loss represent risks of failure. To help reduce these risks, I like to use the lateral decubitus position with a second strap for distraction. I'm able to stand at the head of the table and move around on both sides to facilitate instrumentation. And most importantly, it's easy to put a scope through the anterior superior portal to be able to look down the anterior aspect of the glenoid where the work needs to be done. The posterior portal is used for initial visualization and then for subsequent instrumentation. And the mid-anterior portal is a suture management portal. Frank did a study in 2014 and looked at recurrent instability after the type of procedure and found that with beach chair, there was statistically more failure, more instability than with the lateral decubitus. And I think this is because of the ability to visualize is superior with the lateral decubitus. This is the same patient. This is a view seen from the posterior portal. The picture on the right is a view seen from the anterior superior portal. And this allows you to mobilize the capsulolabral tissue and create the black hole that you need to be able to see to mobilize the capsule for a successful repair. Sometimes you'll also see an engaging Hill-Sachs lesion. This is indicative of bone loss and a indication, especially in primary repairs, for a Hill-Sachs or for a remplissage procedure. The rules of suture anchor insertion should be at an angle on the articular cartilage margin, solidly into the bone. You don't want to skive off, injure the articular cartilage, or break out inferiorly. The inferior anchor, which should be double loaded, should be at either 5:30 or 6 o'clock position. I don't think the actual anchor position is as important as where you put the sutures. And you use at least 3 anchors located below 3 o'clock in the anterior clock face. You need to address the loose capsule. I use a pinch tuck stitch that I learned from Steve Snyder that goes through the capsule, then through the labrum, and that allows you to elevate and reduce the patulous inferior portion of the joint with this single stitch, and you do it at each anchor. The ultra-high molecular weight polyethylene sutures will slip, and a sliding locking knot is critical. Do not use a Duncan's or Fisherman's loop. Instead, the Tennessee slider or the SMC knot are preferable. And you should back these up with at least 3 alternating half hitches. There is a new pre-tied knot available on some glenoid anchors, which also serves the function of secure knots. And to balance the anterior repair, the posterior inferior capsule is plicated using a figure of 8 stitch. The cross stitch, as I call it, is able to obliterate that patulous capsule inferiorly and have a good elevating effect on the glenoid, on the humeral head over the glenoid. Well, what about bone loss? Should you do a Latarjet or a Bankart plus a remplissage? The Latarjet has a high complication rate with almost 15 to 17% recurrent instability in the study by Yang. They lost external rotation with Latarjet and had significant graft reabsorption. Part 2 of the American Board of Orthopedic Surgery database showed that of the 7,500 instability cases, 99% were done using Bankart procedures, and 1% were done using bone block or Latarjet procedures. Unfortunately, the complication rate for the Latarjet was 20.8%, which compares very poorly to the 5.4% complication rate with the Bankart procedure. Remplissage is a key element, and it works best as a primary surgery, not a revision. It is for soft tissue, low-risk procedures, and does not replace significant bone loss. When you do the remplissage, make sure you do not put the anchor medially, because that will restrict motion. There is a safe zone that is used, that was described by Garcia, which is 1 centimeter to the lateral of the posterior lateral corner of the acromion and 3 centimeters distal. That portal will allow you to place your anchor in through the infraspinatus tendon and into the Hill-Sachs lesion nicely for this repair. A systematic review of 6 studies with Bankart remplissage for bone loss found the recurrence rate was 5.4% with no significant loss of motion. The remplissage technique starts off by evaluating the articular cartilage loss and the Hill-Sachs lesion, and then putting a biodegradable biocomposite suture anchor, fully threaded, in the area more lateral and medial to the articular cartilage. I like to use double threaded anchors. I use a penetrating grasper to go in and grab the suture and bring it out in a mattress stitch fashion. So with 2 sutures, you have 4 passes. These sutures are then brought out through the bursa, which has previously been cleaned of any bursal tissue to allow good visibility of these sutures once you have them there. Now we put the anchor for the remplissage in first before the Bankart procedure, but we leave the sutures untied. Then we address the Bankart procedure. You see the cross stitch back posterior and inferiorly, and then the Bankart, 3 Bankart anchors anteriorly, repairing that. So once the Bankart has been completed, the remplissage is tied down, tenedicing the infraspinatus tendon to the area of the heel sacks. Which anchor do I use? I like degradable anchors, and I use a biocomposite, which is osteoconductive. I like the BioCro Repeat material, and this comes in a double-loaded, partially degradable suture, suitable for arthroscopic insertion. This osteoconductive anchor has been shown to be nearly completely or completely reabsorbed in 50% of the instances. A study 3 years post-rotator cuff repair of the BioCro Repeat anchor, the LXVI, showed complete anchor reabsorption in all cases and almost 80% ossification present. We divided these anchors and classified in 4 different types, type 1, 2, 3, and 4. 3 is nearly completely ossified, and 4 is complete bony integration, showing osteoconductivity. 50% of these had nearly complete or complete ossification, which is consistent with the 50% number we found with the BioCro Repeat used in the Milagro screw for ACL reconstruction. Postoperatively, we need to go slow. We immobilize these patients longer than normal, keeping them immobilized for 6 weeks. We delay full contact sports for 6 months. The principles for success are using 3 or more anchors placed on the articular cartilage below the 3 o'clock line in the anterior glenoid. We repair both labrum and capsule to eliminate the patulous capsule, and then balance this with a cross stitch posteriorly and inferiorly. We secure all these knots with internal locking stitches, knots and reversed half hitches, and we make sure we look for the Hegel lesion, which can really be only appreciated through the anterior superior portal. So which anchors do I use? I use biocomposite anchors. I do not use suture-based anchors, which avoid a postage stamp lesion. I use double-loaded in the inferior anchor and balance the posterior and anterior repair with a cross stitch. With bone loss, I use a remplissage, making sure that the anchor is more lateral in the heel sacks lesion, and if there's a bone fragment, I incorporate it at the time of the surgery. Thank you for your attention.